Welcome to the first of 4 sessions in the Trends in Behavioral Health webinar series. Today's webinar is titled, Is Your Organization at Risk for Patient Brokering? Perhaps Preparing for SB1228 and Impending Changes in California's Regulation of Addiction Treatment Marketing. I'm pleased to welcome Harry Nelson, founder and managing partner of Nelson Hardiman. Harry also serves as chairman of the Behavioral Health Association of Providers. We're also joined by Paul Gilbert, a member of Epstein Becker Green's Healthcare and Life Sciences and Corporate Services Practices. Before we begin the presentation, please note that today's webinar is being recorded and participant phone lines will be placed on mute throughout the program. You're welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed again at the end of the presentation. In approximately 2 to 3 business days, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. At this time, I'd like to turn the presentation over to Harry.
Thanks so much. It's great to be with everybody this morning, and we're excited for this kickoff to the Trends in Behavioral Health series between Epstein Becker Green, Nelson Hardiman, and the Behavioral Health Association of Providers. We're going to be having, this is the first of a series of 4 webinars covering breaking issues in the industry, and we're thrilled to be collaborating on behalf of myself, Nelson Hardiman, and the Behavioral Health Association of Providers. We're thrilled to be collaborating with Epstein Becker Green, and particularly glad to be presenting today with Paul Gilbert. At the outset, I just want to say that for this first webinar in the series, I'm going to be playing the sort of first chair role, and you'll be hearing mostly from me with some important color from Paul, who brings not only a perspective nationally as counsel, but also from his work inside organizations providing behavioral health services. And we're going to be flipping these roles as we go on the respective webinars. So with that, let's get started with our topic today, which is patient brokering, and particularly some of the breaking changes in California. We're going to be looking at 4 topics today. First, the topic of how patient brokering got to be such a problem generally, with some specific references to California. Second, a look at why existing laws have not been enough to stop the problem of patient brokering. And we'll be looking at new laws, in particular at SB1228, which is the California bill that is sitting on Governor Brown's desk, and 2 other soon-to-be laws. I am proud to say that I believe today's webinar is the first presentation discussing these bills, and we are, in fact, so early that we are actually, the bills aren't, in fact, law yet and are sitting on the governor's desk. And finally, we'll be talking about the topic of what next, implications and preparing for changing regulations in California and beyond. Let's get started. So how did patient brokering get to be such a problem? We wanted to spend a couple minutes just looking at the problem, defining terms, and really understanding what was happening here. Let's turn first to a definition of patient brokering. We're going to be looking at a specific definition in California's new law, but in general, when we talk about patient brokering, we're talking about giving or getting something of value, money or otherwise, that induces a patient or client referral. I deliberately use patient and client because in the context of addiction treatment, we are sometimes talking about specific healthcare services and in other cases, services that for providers who refer to their people receiving services as clients. Traditionally, within the broader healthcare context, we refer to this whole issue as an issue of kickbacks, right, of the money being exchanged or other value being exchanged as kickbacks. But the term patient brokering has come to the fore, and in some ways, I believe it's a reflection of the way that these practices have devolved into an issue of body brokering, another term that's used, and patient trafficking. And in fact, when we look at the bill, we'll see that the term trafficking and the reference to human trafficking actually is a unique aspect of how this issue has manifested in the addiction context. With that, let's turn to a little bit of the California context. So the Orange County Register has played a leading role within the state of California in calling attention to patient brokering. We're going to be talking a little bit on this webinar about the way that patient brokering has manifested around the country and has received particular attention in Florida. But the Orange County Register has played a significant role, particularly in its coverage over the last 2 years of this particular problem and other issues in drug rehabilitation in California. And we'll be talking specifically about Orange County as a epicenter of the problem and a focal point of law enforcement attention. Let's turn to the next slide. I wanted to just sort of give some context because the reporting of the Orange County Register has been a significant driver of some of the laws that we're going to be looking at, and it's also for anyone on the call who really is trying to understand what's happening and how this issue has manifested in California in particular. We encourage you to go to the Orange County Register. I've included the link there, and I wanted to credit the reporters who have done so much journalistic work. It is very troubling to look at some of the reports, but the journalists, including Terry Sforza, Tony Saavedra, Scott Schwebke, and others, really deserve credit for bringing public attention to issues in California. And I took some of the headlines here just to sort of to highlight how this issue has manifested, not only in California, but in a particular California perspective. We'll see, one of the things that runs through some of the headlines here is that this issue is not merely an issue of fraud, but really has gone to two core problems, one being the ineffectiveness of treatment, as evidenced by the headline, "Many Recoveries Fail to Deliver," as well as the issue of patient safety, headlines like, "A detox can end in death." So this has been there have been some in the addiction recovery community that have complained that the reporting has been sensationalized. Unfortunately, you can read for yourself. There is a wealth of stories of tragedies and problematic conduct that has driven attention to the issue of patient brokering. Let's turn to the next slide. So I wanted to offer two perspectives on how patient brokering has gotten to be a challenge. One is a perspective that we bring as healthcare lawyers, that I bring, and on the next slide we'll see the perspective that the legislature articulated in the law. So how did patient brokering get to be such a challenge? When we look at the law, what we see is that in 2008 we had a significant change in federal law with mental health parity, prohibiting discrimination on the part of health plans between medical surgical services and behavioral health, mental health, addiction treatment services, and that was the beginning of an end to the sort of separate, disparate treatment of behavioral health. And we'll be talking on future webinars more about that law. In 2010, with the Affordable Care Act, we actually had the first affirmative mandate that insurance benefits needed to include treatment for substance use disorder services. And so what that did was open up an enormous wealth of insurance and government funds. And while that was a tremendously important thing from the standpoint of providing access to care, it also led to opportunism around insurance reimbursement and profit-seeking and bad behavior, which is at the core of the issue of patient brokering. And then what happened was in this environment was that a lack of standards and relatively limited oversight that had been a historic relic of the way that addiction treatment had largely not been reimbursed by insurance and had been a much smaller and different industry, led to a lack of policing and essentially law enforcement on the ground, regulators at the state level, and legislators in Sacramento and around the country were really caught by surprise and began a process of catch-up. And what we're going to talk about today is really an important step, several important steps of catch-up that we're seeing occur. So that's a perspective. That's a healthcare lawyer's perspective on how we got here. Before we get to the legislator's perspective, I really wanted to just break down what we see as 4 underlying problems that relate to patient brokering. So the first 3 issues, fraud, abuse, and waste, are issues that manifest at any time you're talking about patient brokering in a healthcare context and the issue of kickbacks. They begin with the issue of fraud, which although we conventionally think of as just being intentional misrepresentation, in healthcare really refers to the issue of submitting claims for payment to which the person submitting is not entitled, to abuse, a broader set of practices where the behavior is inconsistent with sound fiscal, business, or clinical practices and results in unnecessary costs or quality of care that's below recognized standards, reimbursement of medically unnecessary services, and waste, essentially ineffective treatment. So in the behavioral health context, the issue of standards, of recognized standards, is a challenge because we are still in a period where, particularly in addiction treatment, evidence-based standards are still very much in development. And the issue of waste it manifests uniquely because we have such a large problem, whatever, depending on whose number you use, somewhere between 20 and 24 million Americans suffering from a substance use disorder, and a relatively small number actually getting access to treatment, so that when you see a pattern of ineffective treatment where patients or clients are cycling through treatment programs and relapsing, that's a problem, right? Some of that is inherent in the nature of addiction as a chronic condition, and relapse being part of just something that we need to adapt to as we develop standards for addiction treatment. But part of it is also a problem of ineffective treatment. And then there's this 4th issue, which is really has been particularly unique to addiction treatment, which is that the kickback issue has led to a profound safety problem and unprecedented numbers of patient deaths, whether from overdose, from suicidality, from mismanagement of care, not receiving timely and appropriate care. Much of this may be the coinciding of the time period we're talking about in which addiction treatment has grown, coinciding with the opioid crisis. But in any event, it really makes patient brokering a different issue in this context, simply because it has led not merely to financial fraud and harm and ineffective treatment, but to a series of very troubling, tragic headlines and statistics on the numbers of patients suffering harm and dying from being in the wrong settings, not getting enough clinical oversight, and having choices about their care driven by the finances rather than what's clinically appropriate. So for our last slide in this section, I wanted to just contrast the legislative findings underlying the bill, which connect to what we're saying but present a slightly different view. These are this is a summary of what the legislature's findings were in making the change in law. And what the legislature referenced was that the opioid epidemic is a nationwide scourge. They used the statistic of 1,925 lives in California. For anyone who's paying attention to Center for Disease Control numbers, we saw a couple weeks ago the 2017 data showing 72,000 drug-related deaths in nationwide, and then a problem of only 1 in 5 patients actually who need treatment. And here there's a distinction. They're noting the opioid use disorders as opposed to substance use disorders, which is a subset. But in any event, only about 20% of people who need treatment getting treatment. They reference desperation in the need for treatment, fueling a surge in the practice of patient brokering or trafficking, which I mentioned before, with unscrupulous services referring patients to programs that are not appropriate for their needs in order to gain insurance to access to insurance payments. And the law was framed as a law that was focused on safety and security for people in recovery and ending this practice to increase the availability of quality recovery services. So that's the legislative perspective. Yeah, go ahead, Paul.
Anyway, sorry, it's Paul. We have a question in. I wanted to just put it to you real time. The question is this really an issue for opioid and addiction treatment? Is that where it's most commonly seen, or is it a broader issue for behavioral services generally?
So, Paul, I love your comments on this, but my reaction is this issue is my sense is this issue is occurring everywhere. We see this as a broader issue. You know, the challenge is that the opening up by mental health parity and the Affordable Care Act of new access to insurance money inevitably brings with it opportunism. That's sort of embedded in human nature. So I don't think that this issue is limited. It's just that we've seen addiction treatment grow as sort of the frothiest area of growth within behavioral health. But I'm curious if what your perspective is.
Yeah, that's absolutely my view as well. I think the most sensational headlines are very often tied to addiction treatment, unfortunately. But certainly, this is an issue that is prevalent sort of across the industry. You know, from adolescent behavioral treatment, you know, through gero psych. So yeah, it is an industry-wide issue in my view, and certainly I've seen it in many aspects of the industry.
I do think it's interesting that. Yeah, no, I think it's a good question. I do think that the opioid crisis and the role of opioid overdose deaths has been a particular you know, driver of media interest and public interest and the legislative action here. And right. So, yeah. Right. So it's going to be. We can. So this point will come back as we get closer to further in. But let's move. In the interest of time, let's move to the second section, which was the question of you know, why isn't existing law enough? And to look at this issue, we also wanted to address the issue of, you know, why isn't federal law enough? Why are states having to pass laws? And also maybe use this section of the talk to address a little bit of the contrast between California and other states, in particular Florida, which has been the other major epicenter and has taken a slightly different approach to California. So let's move into the issue. So I tried to just basically come up with sort of core points to understand about why existing laws have not been enough. And we'll talk about each of these points on the next few slides. But the first point is that the core federal anti-kickback law, which addresses brokering, doesn't technically apply to outside of the context of federal health programs like Medicare. What we have seen is that this problem has been so severe that federal law enforcement have used tools in their arsenal to get involved, but they're selective about where to do so. So the important point here is that it's critical, whatever state you are in, you need to be paying attention to the law in that state because that's going to be the driving source of law in this area. And here in California, as in many places, we had pre-existing laws, and we'll look at two specific examples where the laws were they were framed to deal with other issues, with issues around doctors and health professionals and hospitals and other health facilities, and they predated addiction treatment and really didn't cover it. There's also an issue of confusion about what options are available to law enforcement and regulators under existing law. And then we get to this critical challenge, which SB1228 seems to be squarely addressed at, which is that the regulatory oversight agency in California for substance use disorder treatment services, the Department of Healthcare Services, DHCS, has had its hands full with this explosive growth of the industry and really limited resources and personnel relative to the need to address the problem. We've also had a related problem of other state law enforcement agencies not having sufficient resources to focus on this. And so the problem has been left basically to local district attorneys in particular counties, and I mentioned Orange County in particular, who have focused on this issue, and they're an exception rather than a rule. But before we go into the details, Paul, I'm just curious if you have any other thoughts on sort of this overarching question of why we need new patient brokering laws, or why there's been a perceived need for them with respect to addiction treatment and behavioral health.
Yeah, so I think the incredible sort of patchwork framework that exists among the states right now is an important reason to think about these in a broader sense. The burdens on providers as a result of that patchwork quilt, are much higher than they need to be, especially in an industry that often runs small programs by necessity. I think it's also, in terms of laws and enforcement, I may be jumping the gun a little bit on you, but while I'm talking, I think it's important to note that government entities are not the only ones interested here. Commercial payers are very interested in this topic, and often will review practices that they are concerned about, marketing practices, for example, short of patient brokering, but then certainly patient brokering under the terms of their agreements, and they have the right to do so under virtually every agreement I've ever seen. In fact, some of the more serious cases that have been prosecuted have started with reviews by commercial payers, ultimately with the case built internally at the commercial payer and then turned over to law enforcement. I think their incentives are pretty clear. Harry, you've spoken to them. I think sort of, patient safety, they're concerned about medically unnecessary care, and the obvious one, in addition, hopefully, to safety, is the higher costs that are incurred by commercial payers if appropriate treatment is not being provided to appropriate candidates. So yeah, I think we need to make sense. It would be nice to make sense of this patchwork of regulation, and as we think about that patchwork, I think it's really important to think about commercial payers and their ability to come in and review your operations, even if you don't think that you're a high-risk target because you don't participate in a government program.
That's an absolutely critical point that Paul just made. I just want to underscore it, that so much of the frontline work is being done by health plans in reviewing claims coming in. And what's happened is that the special investigation units within these plans have been essentially assembling data not only for their own response to insurance claims, but to cooperate with law enforcement. And we've seen several highly publicized local cases where everything about the case, the investigation really was done, and the lion's share of the work was done in the insurance company, and then it was turned over to the government agency for prosecution. So critical for people to understand the unique role that health plans are playing in addressing the issue. Let's move on, just in the interest of getting to the good stuff of the slide. I wanted to give a little more background. And so I mentioned earlier, just for anyone who wants to do a deeper dive, why federal law isn't technically enough. We have a federal anti-kickback statute. I put the reference here. Anyone who works in the environment of Medicare, Medicaid, or other federal health programs will be familiar with it. And the issue has been that the lion's share of reimbursement for addiction treatment has been coming from other sources, from commercial insurance, from employer plans. Certainly, this is relevant for anybody who's receiving Medicaid benefits, addiction treatment, substance use disorder treatment, but in general, the core federal anti-kickback law does not apply to private claims. What's been particularly interesting to watch over the last 5 to 10 years has been that the federal law enforcement has seen the problems occurring in behavioral health as so severe that they have found other avenues to prosecute patient brokering. This has been most tangible. We've seen this the most in the area of urine drug screening and prosecutions against labs and marketers. And I reference on the slide one of the core federal laws, the Travel Act, which has nothing to do with insurance or healthcare or substance use disorder treatment, but is a federal law that prohibits the use of the mail or interstate travel to engage in criminal conduct. And there's a series of other federal laws like this, the law called the Honest Services Act, the Wire Fraud Law, and a few others. And what we've seen is that the federal government has really stepped in selectively because particular problems have been seen as pandemic around the country and needing attention that the states and local law enforcement have not been able to provide. So that is something that's happening, but it's still not the core function of and core focus of federal law enforcement. This is first and foremost a state legal issue. So let's turn to state law, Paul, unless you have any thoughts about that. Sorry, let me, Paul. I didn't mean to. Let me try this again. So before we get into, I want to talk about California in a minute. But before we talk about California, I think it's very useful to look at Florida. And I wanted to, Paul, turn it over to you. But just as to provide context for everyone listening, what's really striking is that Florida, which took on some of these issues over the last couple of years, has really taken a different approach than what we're going to see in California. Paul, do you want to talk about the Florida response to patient brokering?
Sure. I apologize. I actually got disconnected for a moment. So Florida, like California, is an extremely active state in terms of regulation around these issues, the issues that Harry has done such a great job of describing to us. Harry, as you know, Florida was the first state, at least to my knowledge, to adopt a comprehensive regulation and substantive regulation with real teeth in this area. And so the operation of facilities in Florida certainly must be conducted pursuant to these regulations. And the penalties, as I suggested, for not doing so are tough penalties and penalties that really nobody wants to face. The level of enforcement activity and attention being paid in Florida, I would also suggest is very significant when compared to other states. Like California, Florida has for years been a focal point for the location of certainly addiction treatment centers, but other facilities, including behavioral facilities. And this is, if you want to look around at model laws that could be coming to your state and could be directly relevant to you, I would suggest that Harry's view in California and then this slide about Florida will provide you a good baseline for what could come and what we might expect to see as other states become more active, which, personally I think they're almost certain to do, given how prevalent this issue has become and how much attention in the media that it's getting. So I certainly look for this sort of statute to be passed in other states, perhaps not as strong, but this kind of statute. I think, Paul, it's a good point. I think it's very, very useful to look at Florida because when we look at California, the reaction of many to the California law we're going to look at is that it's quite mild. And when we look at the Florida response, we see that it includes criminal felonies and has already been used quite aggressively in ways that California's incoming law does not allow. So this will be a useful point to come back to, and for anybody in other states, very important to really get a sense of the spectrum from Florida to California in terms of government response. Let's turn to the California law, and I don't want to spend too much time here, but just to give perspective, I mentioned that California laws that predated the growth of behavioral health and addiction treatment and insurance reimbursement really didn't cover most addiction treatment programs. There's California Health and Safety Code Section 445, which has this concept of a health-related facility, but when you actually dig into that definition, it doesn't seem to cover licensed residential substance use disorder treatment or certified outpatient treatment, which we'll talk about in California. We also see that Business and Professions Code Section 650, which is California's primary anti-kickback law, really focuses on health professionals. So it does have some application in addiction treatment when physicians are involved. For example,
when kickbacks are being paid for patients to be referred for implants, for naltrexone or other services, as we've seen from recent prosecutions. There are places where it comes into play, but it doesn't fundamentally cover residential treatment for substance use disorder services or outpatient programs. There's a third law that sometimes people refer to in this context, Insurance Code Section 1871.7, which refers to capping, steering, and running. But again, these laws have not fundamentally covered addiction treatment facilities and programs. Let's turn to the next slide. There are two places that are important to note. So it's a mistake for anybody listening who thinks that there aren't already laws that capture this in California. The main law that criminal law enforcement has used has been Penal Code Section 550, which makes it a crime to submit false or fraudulent claims for payment, and in particular to conceal anything that that affects a person's insurance benefit. And this is understood to this law covers the situation where an insurance claim is submitted where there has been a kickback paid. So that law does apply, and that is what criminal law enforcement agencies are using. There's also Insurance Code Section 750, which makes it a crime to accept any, give or get any money or other value for referring patients that lead to insurance claims being made. So there are laws on the books. The issue has been that the state regulatory agency has not had a full set of tools to use, and these laws are narrower. They are specifically focused on insurance reimbursement claims being submitted, and they don't apply to cash pay insurance treatment where it's directly coming from the patient or patient's family to the facility or program. But there are laws on the books that people should be aware of. Let's turn to the next slide. So we're going to now move into the new law, or I should say the new laws, because there are really three important changes about to come into California. And let's get started with just a little bit of background. So there were a whole slew of, there were actually at one point as many as 17 bills before the California legislature this session, beginning this winter, where we saw different approaches to how to fix substance use disorder treatment and address other issues in behavioral health in California. On the issue of patient brokering, there were it really came down to two bills. I should say, in the interest of full disclosure, that BHAP actually prepared a bill. Some of the language ended up in one of the bills we'll talk about, but really it was these two other bills that were essentially folded into one. The bill that's actually passing, or that passed the legislature and that is sitting on Governor Brown's desk, is SB1228. It was originally, this was a bill sponsored by Senator Lara, who's the Democratic nominee for Insurance Commissioner in California. It was controversial with law enforcement and particularly with some of the coastal communities and Orange County in particular, who were upset that from the inception it never included any criminal penalty, and it also it essentially carved out referrals to sober living homes with a idea that there would be voluntary certification of sober living, which we'll come to. So people thought that the original bill was not tough enough, and they wanted there was a desire to have felonies like Florida put in place and jail time for people engaged in patient brokering. The problem that happens in California is that anytime you pass a law or you pass a bill that establishes a felony, a new felony in California, it must go through the Public Safety Committee because it's going to affect jails in California, and where the prisons are already being viewed as overfull with violent offenders. And so public safety is a place which is notorious for killing legislation. So this bill included no criminal penalties. There was this other bill, which is really the source of the real language, which was more of a compromise approach. It originally included a criminal misdemeanor, not a felony, but that language was removed. And it was a bill that the Behavioral Health Association providers supported. Particular credit for the language has to go to the California Consortium of Addiction Programs and Professionals, this was the language that they supported. One of the things that was really interesting was that there was a significant amount of the bill that had that referred to the issue of patient brokering and standards more generally in the context of sober living, and that was all taken out. We're going to see that that was partially addressed in the new bill, SB992, but that was also a source of unhappiness, and some of the original supporters of this whole effort expressed frustration that this bill doesn't really tackle, the final bill doesn't tackle the issue of patient brokering. So let's move on to look at the actual, what does SB 1228 do? So SB 1228 establishes two new statutes. The first one, and the core one, basically creates a prohibition on licensed residential SUD treatment facilities, substance use disorder treatment facilities, certified programs, which is referring to outpatient programs which are not licensed in California, the people who are employed by them or work for them, and the owners, officers, directors, and people who, shareholders who hold more than 10%, are specifically prohibited from giving or receiving anything of value in exchange for referring a patient to any kind of substance use disorder service. There was no, in the final bill, the statute does not include any criminal misdemeanor or power for law enforcement. It authorizes the Department of Healthcare Services, the state regulatory agency, to investigate and impose sanctions either on the program or facility or on the professionals. It gives them extensive power to impose sanctions, and critically, it authorizes the department to continue to implement, not only through the traditional process of promulgating regulations and giving notice, but through publishing guidelines and bulletins, which gives the department extensive power to put out a lot more detail on this law. Let's turn to the next slide and just cover the second piece of SB 1228, and that is a further authorization for the Department of Healthcare Services to investigate violations, assess penalties, suspend, revoke licenses, deny licenses, and also to investigate and take action against the both licensed professionals, that would refer to people like mental health professionals or physicians who are providing services in a program, treatment facility or program, and also to addiction treatment counselors. This basically also allows a referral to the licensing board in the case of people who hold a license. Anyway, so that's the core, this is the core language of SB 1228. And let's turn a little further, and we will, so what's the status of SB 1228? So this bill is going to become law. There were at no point did any legislator ever vote against it. There were questions, and there was some tension that we'll talk about on different pieces of it, particularly around sober living and this issue of the lack of criminal penalties. But the California Department of Healthcare Services has weighed in and made technical amendments which were accepted by the legislature. And essentially, 1228, which 1268 died when all its language went into 1228, it passed on what's called a special consent, where it was not contested. It was a whole package of legislation that didn't have an individual floor vote. And so that means it's sitting on the governor's desk. Governor Brown has until September 30th to either sign it, allow it to take effect automatically without his signature, or to veto. And so sitting on this call, it's dangerous business to make predictions, but I am saying with a fair degree of confidence that this bill will take effect on January 1, 2019 and become the law in California. Let's turn to the next slide, because I also wanted to talk about two other bills that are very important to understand to really get a full picture of what's happening in California. So I mentioned that there was some unhappiness about the pulling out of sober living, and there's an important bill that has an interplay with SB 1228, which is SB 992. This is a bill that that establishes a new mandatory disclosure of any relationships between sober living homes and licensed treatment, residential treatment programs, or certified outpatient programs. It requires any disclosure of not only ownership or control, but contractual relationships. So it's a new disclosure, and along with that came this new definition, which is the first time in California law that that sober living, now called recovery residence, has a formal definition. As I mentioned in one of the earlier slides, there's been an interest in regulating sober living, as Florida has done with a voluntary certification process, but the bill didn't go that far, but it established the definition, and I believe is a precursor of a future effort to bring certification and more regulation to sober living recovery residences. There was also one other important bill to talk about. Let's move to the next slide. Sorry, one other point on SB992. It had a this bill also had some new prohibitions that any operator in California need to be paying close attention to. There is a new requirement, new standards about how to handle the issue of relapse, a recognition that it is a problem that needs attention. Facilities are required to include details of how they're going to deal with it, so that there are some important operational changes that anyone operating a substance use disorder treatment facility in California need to be paying attention to. And there was also, let's turn to the next slide, a critical assembly bill. Let me move to the next slide. AB 3162. Assemblywoman Friedman was the primary sponsor of this bill, which is also sitting on the governor's desk, also passed the legislature, which tightens up safety on a number of issues in facilities. It establishes a new provisional or one-year provisional licensing scheme, but what's critical for anyone who's operating in California is that it establishes that all treatment services must happen at either the licensed facility or an address that's identified on the license, that no one other than a resident of a residential substance use disorder treatment facility can be on-site receiving services. So those are significant changes. One thing that just to note that was very important was that bill at one point contained a density restriction that coastal communities, Orange County, and others had advocated for to limit the density and the perception that there are too many addiction treatment facilities being aggregated in various locations, and so that language came out of the bill and is deferred for the next legislative session. So,
Terry, I have another real-time question, if you don't mind.
Yeah, please.
I think it probably fits in best here. So, and I'm paraphrasing this question, but given the environment in California as described, including the new legislation, what would you say to a provider who's thinking about sort of a risk-benefit analysis? Apparently, they have some level of concern about kickbacks at a call center, and they're not sure. Apparently, they understand they're benefiting from those activities at the call center, but given the enforcement environment in California, they're curious about whether they can weigh the benefits, if you will, of these potential kickbacks against the risk of enforcement. What would you tell them?
So it's a good question. I think that it's a tricky situation right now because there's very little guidance out there about the issue of call centers, as on many issues that we'll talk about on one of the upcoming slides. So, you know, our reference point has been to look at what California law enforcement and the Attorney General, in particular, California Attorney General has said about the issue in its advisory opinions, and also to reference, you know, Medicare OIG opinions, which have addressed the issue of call centers. So we've seen that, you know, there's a whole spectrum of activities happening within call centers, for example, between highly qualified leads that look essentially like a payment for a patient who's already been completely vetted, to you know, to less qualified leads, and where there has been some allowance under federal law, and relatively little enforcement in California. So I think that the whole point of the new law is that the Department of Health Care Services is likely to weigh in on all issues on all of the many issues, and we'll talk about the whole set of risk issues, and we're likely in the next couple of years, as a result of the bill being passed today, to get some very clear guidelines, or maybe more, I would say, have some clearer guidelines about the particular risk-benefit analysis. For the time being, it isn't there, so all we can do is look at enforcement on the ground, the California Attorney General, Medicare, and I do think there are reasonable. Personally, my view is that there's a whole spectrum, and there are reasonable and unreasonable ways in which call centers are being used, and it's really a deeper dive on the particulars of for every organization.
Right. Yep. Thank you.
So, should we move forward on the last? Let's kind of get into the implications. So, just one last slide, and then I want to open it up, and Paul and I will kind of give you some thoughts and take some more questions, hopefully, on where we go from here. But the kind of in reading SB1228. As my answer to Paul's question sort of highlights, the devil's really in the details. SB1228 is really an effort to put the Department of Healthcare Services front and center with the power to give guidance and make and decide how patient brokering and particular practices will be handled. But we're going to have to wait on the department to address issues. I can tell you from personal experience that we have found the department is actively thinking through issues and is engaging in questions. Our purpose on this webinar isn't to grade the Department of Healthcare Services, but I fully expect that we will be seeing significant clarity coming from them, and encourage everybody on the call to either, whether you do it directly or through your attorneys, to be engaged with Department of Healthcare Services and paying close attention to what comes out of them on these issues with the new powers that they will have effective January 1, 2019. So, one thing to note in the law is that there is no safe harbor as we have under federal law. We often make reference, and Paul, I'd love your thoughts about this. When people ask, we often refer to the federal safe harbor standards, which talk about the permissibility of providing services, including marketing, under written, long-term, meaning 1 year or more agreement that detail what services are going to be provided, when they'll be provided, and commercially reasonable fair market value relationships that don't take account of the value or volume of patient referrals. So that's not in this law. That doesn't mean that there's nothing that suggests that goes out the window. It's just there's a little bit of vagueness, and I'm curious what your perspective is on on the issue, and just generally on the issue of how organizations should think about marketing in the absence of clear safe harbors.
Right. So I encourage clients to think about and to consider, and obviously in instances I help with that, but to consider the guidance that is in place, and that primarily is the guidance coming out of the federal government, including case law being developed by the Department of Justice. That's a conservative view, I will grant you, but it is one that I think has served clients well. There is room. I think, Harry, in your previous answer to the question, reflected the range of and the spectrum of risk that people are willing to take on to operate their businesses. My view is, in light of the sort of consolidation in the industry, if you were an organization that you feel might combine with another at some point in your future, in particular, I would say, think about, at least, if you don't follow the government, the federal government standards, because as you get into discussions with another organization, or if you potentially start talking to a private equity firm, for example, I think the expectations of buyers and investors is higher right now than what many state law provisions provide. And so I think you're better setting a higher standard for yourself.
I think that's helpful. just a few other points, and then we can use hopefully use our last 10 minutes to kind of get to what the takeaways are. So I mentioned several points. Sober livings were pulled out of the existing bill, and then we still got some clarification with the new definition of sober living and a disclosure requirement ahead in California. There still is an interesting question about what the status of sober living homes are going to be. We're seeing that this is an area where there's some tension between coastal community resident interests who have, which the addiction treatment community regards as a source of NIMBYism. The coastal communities view this as a safety issue and a disruption into local communities. And then the other interesting wrinkle that came out of this legislative session is that the Department of Healthcare Services clearly is not ready to begin regulating or overseeing a voluntary certification process, even if that was overseen by an outside agency, as happens in Florida with the National Association of Recovery Residences serving as a certifying body. So California has more work to do, but we did see some advancement here. And then the big unresolved issues ahead are, will the Department of Healthcare Services get the funding it needs, and will it be able to put more personnel and resources on the ground, and will more counties in California follow the lead of the Orange County District Attorney in taking this issue, and will the FBI and federal law enforcement continue to see this as a priority? Those are some of the unanswered questions ahead, and the questions that we'll be looking at in the next couple of years. What you should take away from SB1228 is that the Department of Healthcare Services is now a much more active player in regulating the issue of patient brokering. Let's move to the next slide. So, some of the other interesting unresolved issue is going to be the interplay between all of these different agencies at the state and federal level and local level, and how much more regulation we're going to see. The most important issue I would point out on the slide is the final bullet, which is the question of how much we're going to see more regulation of addiction treatment professionals. At the current time, we do not have licensure of addiction treatment counselors. Organizations like CCAP provide a certification, but there is going to be more pressure on and the approach that SB 1228 seems to be pointing to is that California is likely to consider seriously a licensing mechanism for addiction treatment counselors, because that's a way of giving the state more control over more personnel in the addiction treatment context, as it has with respect to physicians and mental health professionals. So let's move to the next slide and talk a little bit about how do you think about this within your organization. We talked a little bit about call centers. I mentioned implant scams, but there are a whole set of practices that I think organizations would be well served to look at in the aftermath of these bills. Questions about your relationships with marketers, issues about how you're dealing with independent contractors and employees, how you're compensating them, what your contracts with them look like, how you're generating leads, and a whole set of high-risk practices, right? Bed vouchers between sober living, recovery residences, and addiction treatment programs, procurement of insurance for patients, urine drug testing, waiving and discounting patient financial responsibility, relationships with healthcare providers, including scams around naltrexone and buprenorphine, which we've seen as a focal point of law enforcement. All of these practices are areas that need attention for any organization that's providing substance use disorder services, or for that matter, behavioral health services. And the law doesn't specifically address them, but again, it empowers the Department of Healthcare Services to weigh in on these practices and to be a more active participant in shaping policy in California. Paul, any thoughts about the, yeah.
Yeah, I wanted to put a question to you. I'm actually combining two questions that we've received that I think go together. And again, paraphrasing, I'm not reading the questions directly. But in each case, the provider, facility owner, seems to be concerned about activities of third parties. So in one case, there is a concern about physicians perhaps paying referral sources to them, I assume they're psychiatrists or psychologists, to admit patients to the facility. In the other case, someone is concerned about a marketing service they work with. They understand that the marketing service pays their individual employees based on the number of admissions that result from the marketing activities, and both ask how far do they have to go to understand exactly what their third-party contractors, in one case independent physicians and in the other case a marketing service, how far do they have to go to understand the business operations and to ensure compliance at those organizations outside of the facility?
I mean, my comment would be that you need to understand any benefits that you are deriving, whether, there's no value in taking an approach of just saying, I don't know what's happening within that organization, or I don't know what those financial relationships are. We've seen over and over again that when law enforcement and regulators get involved, they're not particularly interested in the question of what you knew at what time. They're concerned with the ultimate question of, was somebody being improperly incentivized to refer patients? Did a fraud and abuse occur? And when it occurred, that there's no defense in not knowing about these things. So I would urge anybody who's on these questions, and anybody who's thinking about, am I protected because it's happening away from me? The answer is, if you are benefiting from it, then you are certain to be viewed as part of it. If we had more time, I would give you specific examples of how we've seen that play out, but that would be my general advice.
Yeah, let me also add to that. I think your reputation as a provider is incredibly important, and if an investigation takes place, you're likely to be caught up in the investigation regardless of where the activity is occurring. Investigations are really expensive, really disruptive, and you want to avoid them. So I just echo, Harry, what you just said. Be very, very careful if you have a sense that something's going on somewhere outside of your facility.
So let's move on to just sort of how do you deal with these issues. So these laws that we've discussed today make significant changes, and it's critical to understand them. And as I've said several times, part of what these laws do is they empower the Department of Healthcare Services to make more refinements in the form of bulletins, guidelines, and ultimately regulations. But the point of these laws is to accelerate the ability of Department of Healthcare Services to move, even if it takes them several years to put out regulations, to start putting out active guidance now. And if I had one piece of advice on this, I would not sit back and wait thinking there's going to be a long time before this becomes a problem. These bills mark a significant change in California, and they connect the conversation and the dialogue between local, state, and federal law enforcement health plans, and it's a critical time to look at where changes are needed in your operations, your communications, your contracts, your disclosures, and to develop plans to come into compliance with these laws. Let's move to the next slide and talk about the practicalities of that. I put up here, and Paul, and I wanted to turn this over to you, but for anyone who's listening who's not familiar, I think it's critical to look at the 7 elements of compliance programs that we have from the Office of Inspector General. These are the building blocks that the federal government has articulated, but they provide a very useful framework for how every organization that's thinking about what its responsibilities are to address patient brokering and other issues should think about these issues. And Paul, I don't know if you wanted to add anything about compliance programs.
Yeah, just quickly to reiterate a point I made earlier, investors and private equity firms are very attuned to this particular risk, patient brokering, and the compliance efforts around it. And in particular, I would suggest it's a bit of a litmus test for them as to whether the board is engaged in compliance, what management's level of integrity is, how much do they know, and are they participating? If so, they're a little less inclined, and in fact, maybe a lot less inclined to make an investment. And so investors and outsiders are interested in these. It also, of course, goes to your reputation, because if you're on the front page of the paper with respect to patient brokering, it's not a good thing for your organization. Harry, I have one more question to feed you before you go into your last slide, I think, which is where can someone go if they are interested in opening a facility in California to get up to speed on the California requirements and to become educated about running a facility properly in California?
So I feel like this is a setup question, but
it's not. It's a real question.
A real question, but so so we are actually, Paul, I believe you are going to be joining us, right, and co-presenting on October 21st and 22nd. We actually had, independent of this program, scheduled a boot camp on these specific issues, and we'll be sharing that information through the Behavioral Health Association provider website. So if you are on the list and received information about this call, you should be receiving information about that. But that's part of what our focus has been on, providing nuts and bolts guidance for both current operators and for people who are considering opening new programs to get it right from the beginning, and we'll be glad to share more information about that. So just a final 30 seconds of takeaways. You know, a lot of people I find are confused about whether there's no great clarity that comes out of SB1228 or these other laws. But what we are seeing is that we're getting a more organized system, and even though there's not a one-size-fits-all black and white set of answers to how to market your program or attract clients or work with marketing professionals, there are right and wrong ways to do it. The biggest thing that concerns me when I talk to people in the industry is a perception that everyone else is doing it, we have to do this, this is the only way we stay in business, and that's just not a viable approach as we move forward. And so my final recommendation for anyone reading this and trying to understand it is that there is a moment now to, for anyone who's been taking a sort of bury your head in the sand approach or a fear-driven approach, this is really a pivotal moment to deal with whatever skeletons are in the closet on marketing and other issues, and really to come into compliance and get out of the business of practices that fall within the patient brokering rubric. So unless we have more questions, I'm going to stop there, and Paul, I'll turn it over to you for a final word.
Yeah, just to emphasize, we do have more questions. Let me try to hit them quickly. One, as you said just now, Harry, there is an important distinction between proper, appropriate marketing and patient brokering. They absolutely are not the same thing. Marketing is important for everyone in business. Patient brokering is not. The other is around compliance and whether there are software packages to help providers track compliance with the 7 elements. There certainly are a number of software solutions that help you make sense of your policies and procedures as you grow. I would refer you out to those in terms of policies and procedures, but with respect to tracking actual compliance, you know, sort of boots on the ground, and you know, a call, a hotline, I would say are 2 places to start. So one, auditing practices, finding out what's really happening out there, and then secondly, providing everyone with an anonymous source to call and let you know if they're concerned about something, I think are 2 early steps to take as you grow your business. And with that, I think our time is up, and we certainly thank all of you for calling in and participating. Harry, I let you have a final word here.
No, it's thanks. I want to thank everybody for dialing in today, and hope that everybody learned something and found this valuable. We look forward to sharing more information on this Trends in Behavioral Health series with our next webinar. Paul, I don't know if you have the information handy, or that will be going out soon. But I think that if you've been listening in today, I can say with confidence that you are among the most educated group, because the governor has not yet formally acted on these laws. but we're excited to be able to keep being providing a leading edge information and education. And again, thank you to everybody for participating today.
This concludes today's webinar. In approximately 2 to 3 business days, Epstein Becker Green will communicate the availability of the webinar recording and PowerPoint materials. Thank you for attending.